Okay. Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee for making this nice and very great effort for the last 3 days. And it's my pleasure to introduce my panelists here. We have Dr. Abu Shoka from Sharjah Hospital, Qasimi, and Sundus Samarkandi from Prince Sultan Cardiac Center, Dr. Mohammed Rashaidan, مدينة الملك فهد الطبية بالرياض, King Fahd Medical City, Riyadh, and Dr. Ahmed Al-Shati from Kuwait, and our colleague from Iraq. Your name? Shaukat Miro, and Abdurrahman Durdiri from Medina. And it's my pleasure to receive King Khalid University Hospital, our colleague, Dr. Walid Al-Harbi and Dr. Talal Al-Jabbari from King Khalid University Hospital, King Saud. And today we're going to have, inshallah, a very nice live transmission using one of the self-expandable platforms, and the floor is open for you guys.
Thank you, Dr. Belgates, for the introduction. At the beginning, I would like to thank the organizing committee and GIS for this invitation. And also would like to extend our thanks to Boston Scientific for allowing us to a procedure. Today we present, we will get a rich discussion with you for panelists. But before we start with the team, I would like to introduce our team.
Can you adjust the sound a little bit? Adjust the sound a little bit. It's a little bit interrupted.
Transmission.
Yeah. If they can do anything locally, it will be better from the beginning. Go ahead.
I think, yeah. So I'm going to start introducing the team. I'm joined with Dr. Walid Al-Harbi, an interventional structural cardiologist, director of our cath lab of the cardiac system. We have Dr. Mustafa anesthesia from nursing. We have Osman Abdullah. We have Ricky Faisal. We have Hana, she's our coordinator. Sheikha, she is our cath lab manager. And Rima from ECHO. And we have Ahmed from Boston Scientific. We have also Alphonse, he's one of our senior nurses as well. Can we see the slide, please? Do you guys see the slides?
Dr. Belgates, can you hear us?
And here, yeah, give me this. Yes, we can hear you, we can see you, we can see the slides too.
Excellent.
Continue.
Next. So our patient, she's a 70-year-old lady with diabetes, hypertension, dyslipidemia. She has also a history of asthma, paroxysmal AFib. She was seen initially in the clinic for pre-op assessment as she was planned for laparoscopic hysterectomy due to major uterine prolapse. And in history, she was found to have NYHA class 2 for many years. No history of angina or syncope. In physical examination, you can see the patient is morbidly obese with BMI of 40. In examination, she was found to have significant ejection systolic mirror in the aortic area. Otherwise, she was evolemic. The labs were unremarkable. Next. This is her ECG, so you can see patient, she has AFib with no recurrence complex. Next. This is her echo. So her echo did show tricuspid aortic valve with severe aortic stenosis, mean gradient of 66. She also has moderate aortic regurgitation. There was LVH, but the LV function was normal. She also does have moderate to severe MAC with moderate MS. Next. This is just show you the aortic valve. It's thickened and restricted. Next. The LV function appears to be normal. This is the MAC. You can see there is a severe MAC. Next. This is again from short axis. You can see the aortic valve. There is some calcification. It's restricted and thickened. Next. And this is just to show you the LV function. Next. This is her CT. So you can notice that she has a small valve. Her annulus, the perimeter is about 65.9. Her perimeter-derived diameter is 21. The LVT is 18.5. Next. STGs and sinus of Valsalva were adequate. So the mean sinus of Valsalva were about 30 millimeter. Next. This is just to show you the patient has only mild calcification despite significant gradient. So that tells us that patient probably has a fibrotic valve, which we need to keep in mind because those valves sometimes very, very difficult to expand very well unless you do like appropriate pre, and sometimes you need post dilatation as well. Next. This is her coronary height. You can see the right coronary is adequate, 15.6. However, her left main is very low. It's like 8.3. Next. This is her aorta. You can see there is calcification, especially in the abdominal and aortic arch, but the axes, the femoral axis were adequate. Next. Here you can see there was also LV septal bulge that was detected, and this is important as well to keep in mind during valve implantation. Next. This is coronary angiogram, so you can see the right was a small non-dominant. Next. Left main was normal. The circ was large and dominant with no significant disease. Next. However, you can see the LAD has a severe mid-focal lesion. Next.
Please.
Next. So here I'm going to stop and pause. So we just presented a lot of clinical echocardiographic and CT data that I think we need to think about and carefully plan our procedure. This patient highlighted multiple issues. So we have a morbidly obese lady with a small annulus. She has a low left main. She has a mid-LAD lesion. So I'm really interested and curious here with our team to hear the opinion of your expert panelists how to approach a case like this in terms whether platform you want to use. If you to go with TAVI, is surgical still an option here? What are you going to do in terms of LAD revascularization? In terms of low left main height, would you go ahead and protect in advance or not? And is there any cautions you want to take in case of septal bulge? And given her age is around 70, I think lifetime planning for Redo TAVR should be kept in mind.
Okay, do you want to give me a chance here? I will talk to my panelists and see what is their opinion. We're going to start from the right. Dr. Wild, what do you think? I mean, you are using this platform in your hospital. Which platform?
Like what?
Can just we go back? We had one more question. The sinus size was what? 30?
Was 30. The average was 30.
Yeah, I saw that. It wasn't the 30. Go ahead, Wild.
Yes, I think this is a case you have a good access. You'll go femoral, and the only issue here is a little bit low
left
main. But I think with an accurate neo2, I would be very comfortable to do this case.
We go to Dr. Sindis. Give us your opinion so far with this anatomy. And before we go to that, how you deal with such case in Prince Sultan Cardiac Center with a very well set program for 14 years. And tell me about the dynamics between us interventionists and our colleague cardiologist for such case. She's overweight, she is morbidly obese, and she is not that very, very old, but she is old, 70. For us, 70, it's equal to 80 in the Western countries.
So I agree with their approach that going with the percutaneous option to fix the aortic valve, symptomatic severe aortic stenosis in a 70 years old lady. As per guideline, the North American suggested 65 and above to go for TAVR. European 75, and we have our own Saudi guidelines, which saying now 70 years. So we are within the guidelines. The platform of choice, I would go with the self-expandable because the sinuses, the area is so small. It's 320. Like, we would, for better hemodynamic response, we will go with that. And there is a possibility of, better longevity. Regarding the LAD revascularization, I would not because it's just mid-LAD. and we have a very clean, and she did well for the last 70 years. So I think she's going to have another one. Regarding the lower or the height of the left system, it is co-dominant. So it comes with a risk, but we have something in our favor, which is having a self-expandable, which is my choice. So it gives you a chance to retract if something is not going well with you. Number two, you have a big sinus. It is above 30. And I think we don't have significant calcification under the left main or something that may contribute to protect or not is still an option. It depends on the platform and the experience of the operator, which I don't think is very high. I think it's very high experience, and so they will be doing well. Septal bulge, I will just hydrate the patient very well before it and in consideration, and be careful not to deep seat the guide or be lower. And I think the platform that they're choosing, it will let them more of a control of the valve.
And our colleague surgeon, we are happy to have you with us now. And
well,
need your opinion. Person.
I think choosing a percutaneous option, it's very reasonable in this patient. Having said that, I will not turn her down from surgical because she's 70 years old. I know she's old, but looking at her anatomy with low left main and she's left main dominant, I would still consider doing aortic valve replacement with root enlargement and giving her a bioprosthetic valve with a good size. It's still an option. And also this will help in terms of lifetime planning for a redo, because the redo TAVI on TAVI, it's better than redo TAVI and TAVI. And also the thing is with septal bulge, we can deal with that during the surgery. We can do a septal myectomy, so we can give the patient a full fix surgically. But again, I think the primary team choose a TAVI. I think they have a very good reason to go for that. Thank you.
Okay, Ahmed, great.
Yeah,
You do?
I would go for TAVI for sure for this patient. Again, annular enlargement, cabbage, and valve replacement at this age I don't think it's very variable, in my opinion. I would go self-expandable. Either, to be honest, Boston or Medtronic could do a good choice. It could be a good choice here. LAD, I wouldn't revascularize. I would just do the TAVI. Low left main, yes, but this is very overestimation of the low left main. I think the opening of the left main is quite big. It's like a cone. So this is not bad. And this is like the vertical. This is the stretched view. So this is the worst case scenario. I think and with the big sciences should be fine. Septal bulge is scary, but it's not that scary. I would be more scared, to be honest, of this very small ventricle. I would use an extra small Safari or Inui wire. Something very small, because
If it
the
is
wire
available in the cath lab.
Yeah.
If it is available in the cath lab.
Yeah. So it could be a difficult, one.
Shaukat, what about our Iraqi colleague?
I agree with the colleagues. Probably I would go with the TAVI. And the annulus is a small supraannular design. It is preferred for me. Regarding the left main height, it is 8.3. I think the sinus is quite big. The issue of protection, I don't think it would be necessary for me for this patient.
Yeah, regarding whether surgical or TAVI, her age is borderline, but in our area, probably I will go with her functional capacity. Like, I mean, this is what we do in practice. If the age is borderline between 65 and 70, just we look at their functional capacities and activities of daily life. Whether it's which platform, I think any platform can fit in this anatomy. Though the left main is it's borderline, it's 8.5. So there is no contraindications even to use supraannular valve. Regarding the septal bulge, all the aortic stenosis, they have sigmoid septum and the LVH at the base. But if the LV outflow tract similar to the annulus, I think it shouldn't be a problem. If the problem is the LV outflow is smaller than the annulus, then you have to be careful about a balloon expandable. It may have actually, the septal will not rupture, but the annulus may rupture if you...
Which is not the case here.
What's that?
Which is not the case here. Ahmed, very quickly, please, because we have to let them go. We can hear you.
The absence of calcium and the heavily fibrotic valve, in addition to the affection of the mitral and very large atria, raises the possibility of this patient being rheumatic in origin. So This is number one. Number two, with the lifetime management of a relatively young patient, I think a supraannular position, if you take into account a second valve will be put in like 8 or 10 years time, will form some problems. So I'll be a little bit hesitant to take a supraannular valve. And intraannular one probably is better for the lifetime management.
Same plan so far. Okay, go ahead, guys. Let's know what you are planning to do.
Can we see the slides again? Okay, so this is I agree with most of the panelists. So this lady, we felt like she's very high risk for surgery, so we decided to go with TAVI, giving her high BMI, risk of patient prosthesis mismatch. We decided to go with supraannular valve. Because of the low left main, we decided to go with accurate renew because of the shorter frame. We decided not to revascularize the LED. We'll leave it after. Can I see the next? So we're going to go right femoral. We're going to use accurate neo small, 23. We're going to use commissural alignment to allow for visible TAV and TAV in the future, and also to allow for easier coronary access. We're going to use the left femoral for pigtail. We're going to put a pacemaker on the left side. We're going to predilate aggressively here with 20 millimeter balloon. And if we need it, we're going to use the same balloon for post-dilatation. Next. So here, if you look to the valve durability for TAVI, so our patient is falls in the low risk at the age of 70. So the median survival is about 20 to 13 years. So we expect this lady, she might end up needing a second valve in the future. And that's why it's very important to keep that in your mind and take, like in terms of commissural alignment. If you go next. So we're going to do commissural alignment for this valve, and the way we're going to do it, so we're going to insert the valve with a safety pin at 6 o'clock, and then we're going to go on the cusp overlap on the 3 cusp view. Ideally, you want to see all the 3 posts parallel to each other. If you have 2 on the right side, then you have to do counterclockwise until you have the 3 posts parallel. If you have 2 posts on the left and 1 on the right, then you have to do clockwise until you have a 3 posts parallel. Once you have that, then you have to go to the cusp overlap view to confirm commissural alignment. And in the cusp overlap view, if you see one free stent on the right side of the screen, so that means that favorable commissural alignment is reached. And then you can go ahead back to the 3 cusp overlap view and implant your valve. Next.
Do you want to mention, Talal, to the people who doesn't know that it's different in deployment? It's deployed from top down rather than down top in comparison with the other.
It has a unique design. It's deployed from top down. And this is mainly to provide a more stable, predictable release without needing for rapid beat. But in this case, we need to rapid base because of the septal bulge. We were just worried about it might just symbolize. This is a 3D of the native anatomy of this patient. If you go next. And this is a simulation of the TAVI, index TAVI inside this patient. So you can see the coronary axis will be fine, inshallah. Next. So in case this valve failed in the future, we thought about this. So this is a simulation again. So the only valve has been approved to put in as a second valve for this platform is Sapien, which is balloon expandable valve. So if you position your balloon expandable valve at the upper crown, you will not have any issue in the future in terms of coronary access. If you go to the next slide, please. So you will have no problem engaging either left or right. Next. However, if you implant your Sapien at the base of the commissural post, you might have trouble engaging the left coronary in the future, but the right will be okay. If you can show us next. So you can see it here. Next slide, please. Here I would like just highlight the recommendation for post-dilatation. We all saw the IDE trial, the preliminary result in the TCT. And most of, if you look for recommendation for post-dilatation, most of the operators, they trigger to do post-dilatation if they have significant BVL or they have double-digit gradient. However, we just know from IDE trial that under-expansion is a major issue, which has been associated with worse clinical outcome. So it's very important to identify under-expansion and act on it if needed. Next. So in terms to optimize your valve implantation for accurate new valve and avoid valve under expansion, He needs to have an effective pre-dilatation with the proper sizing. And after implantation, he needs to have a second view, like cusp overlap view, just to make sure that the valve is well expanded in the other view. And this is one of the major limitations of the IDE trial, because they used only one view, which was the three cusp view. And unfortunately, a lot of under expansion were not detected. And then after that, once you identify post under expansion, then you have to post dilate it if needed. Next. So one of the things is, as I mentioned, is secondary view. So if you look here for this example, for example, the valve looks well expanded from the three cusp oblnar view. However, it looks constrained from the right cusp overlap view. Next. The company, after the ID trial, they developed 3 new criteria to identify accurate new under expansion. So the first one is, after valve implantation in the three cusp view, you have to look for the post. Ideally, you should have 3 parallel posts, but if you have non-parallel or angulated commissural posts, that's indicate under expansion, and he needs to go ahead and post dilate. The second sign is if you have valve frame, if the valve frame is taller than wide at the level of upper crown. Because remember, the length of this frame from the inflow to the upper crown is about 19 millimeter, and the smallest valve we have is 23. So ideally, you have to have a wider valve, the width it should be higher than the length. And the third sign is when you have valve inflow is wider than the upper crown, that's an indication of valve under expansion. Go next. So this is an example. You can see patient has non-parallel or angulated post after implantation. And then after post-dilatation with a balloon, you can see now you have a well-expanded valve with 3 parallel posts. I think now we can show you what we have done so far. Dr. Walid.
So the base of operations that we have is that we're going for the valve on the right common femoral, the left common for the pigtail due to very poor pulse of the radial artery, and transvenous pacemaker through the left femoral vein. And as the expert team mentioned, we hydrated the patient. The LVDP reached to 20. Can you show the slide of hemodynamics, please? And excellent. And we have a peak-to-peak of 50 with a clear parvus tardus on the hemodynamics. So we're going to use a Safari extra small for the stiff wire and the LV. And we're going to pre-dill with a 20 millimeter balloon with 1 cc less. And we're going to move forward now.
Let's have the Safari.
And we're going to demonstrate for you the commissural alignment, the valve deployment from knob 1 to knob 2. In addition, how to look for under expansion.
Go Areo.
I have a question. Are you worried, since the patient does have a moderate AI, and you're gonna pre-dilate with a size 20, right? Or you are going with a size less?
20 minus 1.
20 minus 1. Okay.
Usually, in order to achieve effective pre-dilatation, the recommendation is to go with a predicted derived diameter 1.
Yes.
That's why we are going with. We don't have 19, unfortunately, so we're going to go with 20 minus 1.
Facial center.
Okay, let's have the balloon.
Yeah. And we're going to balloon in the cusp overlap.
We tried both, to be honest. We tried the minimal diameter, and we tried minus 1 as well.
Yes.
Yeah, minus 1.
This is the routine recommendation. Minus the diameter minus 1.
This is by both. By both.
Yes,
like
yeah,
by accurate neo. This is what's the advice parameter minus 1.
Yeah. I mean, it's 2 platforms so far in the market. We have to pre-dilate the Abbott Navitor and Accurate Neo 2. And there is already in Europe, they started Accurate Prime.
This is what the big cell,
Centralized?
the cost of the big cell is. The radial force, this is the cost.
The radial force, little bit less
Centralized
than
amount.
usual platform in the market.
Dr. Talal, which balloon you are going to use for a pre-dilate?
20 minus 1, so 19.
Okay.
So I think we're ready for pre-dilatation. So we're going to pace on 80. Okay, I'm going to go
Going up.
Excellent.
Okay,
Okay. Balloon down.
down.
Very stable. Good.
Pacemaker off.
So,
There was no indication for protection, cerebral protection device like Sentinel in this case from the CT scan, like the arch was clear.
Yeah, there's some calcification. The arch, but it was not that
Not
that
heavy.
much.
Yeah. Okay.
Yeah, same thing at the level of the anus, so we decided not to use it. Okay, so let's have the valve.
Okay, it dilated very well, so we're gonna go ahead with the valve.
Hold the fine.
Perfect.
So one of the things that they did very well, that the valve is ready in answer to
Yeah,
the
exactly.
shortly that if you ballooned, you might eat the AI more, but they were ready in case something happened. It's just like 5 seconds away
Absolutely.
from implanting the valve, which is a good
It's a must with all platforms. If you are planning to dilate, keep
ready.
ready, be ready.
Go to the implant view. So we're gonna move on. We're gonna advance the valve.
Sure.
And we're gonna make sure the
There's blood pressure still.
The pressure is great. The
The
position of the wire is great. The position of the pigtail, mashallah, is great. Best of luck, inshallah.
And the wire is nice.
Yes.
It's extra small.
This is the winking sign. That's mean the LV is very thick. It's eating, like it's trying to squeeze the
yeah, small LV, correct. Can you go up, Faisal, a little bit? Okay, good. Keep the wire LV on the screen. Excellent. Okay.
Take your time. We have good time for you and try to explain the alignment and the dots.
So you see, you can see here, it's a 6 o'clock. If you can see the camera, can you zoom in there?
It's like a line, longitudinal lines rather than dots and other.
In the new prime, there's a marker for that. Okay.
I see one on the right from here.
We're gonna try to do commercial alignment.
Sure.
We're gonna try to look for 3 parallel posts. So here, sometimes you cannot see that very well. So
It's clear here.
it looks like
Yes, clear about it. Very clear.
yeah.
You're
all
familiar
yeah.
with it.
Can we go to the cusp overlap? Click. So it seems we have only one free post.
Yeah, I see that on the right.
Yeah. You agree, Ahmed? Yeah. Okay. So we're going to go back to the 3 cusp view, and then we're going to go ahead and implant it.
Okay.
Alignment.
Yeah. So we're gonna advance the marker.
and there is no tension in the system.
Both test man.
Very stable system. Very, very stable. In a good hand, you will not have any suffering, inshallah.
Good.
Okay.
So I'm going to start to open knob 1 until we open the upper crown.
You think you are a bit high, or you're happy?
No,
Yeah.
it's very,
I take a picture now.
very good position. See the dot with the bottom of the big tail? Maybe the big tail little
Forward
bit.
شوية high.
Well,
1 minute.
yeah.
We're gonna move forward. I agree with the comment.
Yes, the big tail was higher a little bit. Yes, it was parallel with the big tail, but I think tiny bit, not much.
Yeah, just a milli.
Yes,
The stabilizing arches now.
this is the first step, and it's again top down. Ready?
Go ahead a little bit
Opening.
in. We're up شوي.
Okay.
Okay, we're going to take a picture, make sure we're in a good position.
You
We need just to go let it attend.
do this.
Can move forward a bit.
Yes.
Yeah.
You can push one stool here. You can do something.
Okay, good. Okay, small cup test.
You complete step 1 completely now.
Yeah.
We'll complete step
Okay.
1.
So we're gonna overdrive rapid pacing here because the
Okay.
septum bulge is a migration. So ready, Talat?
Yeah.
I don't pace rotating. There's no need. It's okay. Do whatever you like.
Yeah, in this case, because of the septal bulge, we want to minimize the migration.
Yeah,
of
the
valve.
bulge and whatever, there's other anatomy here can control you.
The only thing, maybe you don't go to zero pacing.
I will leave them now because they took the knob.
Okay, go ahead. Rapid pace.
Very fast step, which will be avoided in the next generation already, which is in Europe. They don't have this rush. See that step? It's
Pacemaker
done
off.
in the next generation. That's it.
Okay.
Now you're
So,
gonna deal with the wire and centralize your nose cone.
Those come.
so we slice the nose and then we
Slowly,
push the
slowly.
wire.
Take your time.
Take your time.
Yeah, no rush. We are okay. Perfect.
Excellent.
Will you okay?
Okay.
Very, very stable, the whole precision, inshallah, from the beginning so far.
Close.
I think we wanted to try the post dilation in here, and we do the views, which is recommended now by the company.
Yeah.
Let's do the view. Show us how you can tell this is little bit under expanded and
Yeah. You have
Not yet.
I would just before post dilation though, check the pacer because it seems it's moving a lot.
They should
Yeah,
face
yeah. Just so make sure.
just
still in
the
apex,
jail.
huh?
jail.
Still in apex.
Yeah.
The RV. Yes.
that's probably
خليه كده حلو. هو طالع له. That's better now.
It looks good from the three cusp view, but again, we have to look from other views. So we're going to go to the cusp overlap. Can you go to the cusp overlap?
Okay.
Make sure no parallax. What do you guys think?
Looks great to me.
Yeah, it's fine.
Yeah.
You know,
Yeah,
because
I
we are using this pre-dilatation routinely for the last few years, and but it's still, I think, we are recommended now by the company to do the special view to make sure there is nothing like no waste after whatever we heard in TCT.
It's like
But we're gonna do-
hemodynamics to decide about the post dilatation. Maybe it will help.
Yeah,
The
I
views
mean,
looks
if
reasonable.
you like to do gradient, you can put a big tail if you want. It's up to you.
I would say
Or
this is the-
echo, whatever. What is your practice?
What is
Yeah, it's up to you.
You do it.
You control it. You the boss. So far, so
And-
good. I'm happy.
Great.
It's but Prof, I think this is the biggest orifice area the patient had in her life.
Ah, مسكين, yeah. One
mean,
over.
usually in
This is
Italy-
where our colleague surgeons struggle with mismatch, and our ladies, 40 BMI, short ladies, even that's why they do their big work.
I think I will end up by little post dilatation. The valve.
So,
Yeah, he will do great.
if I can get away without
Not
post
full
dilation in 70 years, multiple
Exactly.
orbits.
We will do
Great.
gradient. If
Cannot
we are
do-
happy, I think we will not change our routine, but this is recommendation. If you think post dilation after you finish the case is indicated, it's better nowadays to do it. But
Exactly.
again, it's not a must.
We didn't have any NGO for the left main that we've been worried for the last 20 minutes about, so they can take an NGO.
They can
But
take
ECG
with a
looks
big
fine.
brace, yeah.
Hemodynamics looks fine, so.
No major changes. The conduction is nice, narrow, complex. Yeah.
And I think this less pacemaker implantation is one of the good things about this valve because it's one of the lowest
Yes.
valves that need.
Yes. I mean, we see the pacemaker even with balloon expandable. Yeah. It's beautiful. Gradient is nice.
Dr. Balgate, our population, I think it's different from the population outside. Our calcium is
No
way
doubt.
less.
No,
Is way less than
This view looks
Yeah.
nice.
Dynamic. So tell us, how is your dynamics?
So you can
you
see
see the hemodynamics or you can't?
Yes, we can.
yeah,
Okay.
a minimal gradient, probably 3, 4.
Yeah, single digit.
Yeah,
But,
single.
but just I want from you, Talal, again, go to the same view recommended by the company now. show us what is the view, what is the angulation?
Sure. Implant view.
Because this is one of the major recommendation we received by emails as operator. If you think the post dilation is indicated, you can use this view and do it, but it's not a must. Our practice may be different from too many people in the Western country where they did only 1 or 2 cases and they were included in trials.
So you can see the left main look okay. I think valve is a good position. And there is no significant BVL.
Okay.
And
But now we, yeah, and swirl. And now we need to go to views where we have all the 3 posts parallel to each other. So can you under fluoro go more RAO? More RAO, yes, more RAO.
More.
Okay, stop. Go photo. Photo. So here,
Yeah.
yeah, it looks fine actually, and you can see both like the I don't know. Can you try to go more RAO? Floor. Actually, LAO. Okay, stop here.
Very good.
Or yeah, clean. Okay, and then LAO letter. Okay, that's perfect actually.
Alice.
But Dr. Muhammad, you have no gradient, no AI. You really need the
No, just as a recommendation. I want people, including myself, to get used to it if we will need it.
This is what you're looking is the
Beautiful.
the bulge of the septum. Yeah, I wouldn't push it. So it will. You can't push it anyway.
Very nice. Very nice looking valve. I'm happy. Gradient is single digit. Conduction is beautiful.
Yeah.
We could see the anatomy, and I think I should congratulate you for this dedicated type of procedure in a very stable, calm hands.
Thank you very much. So
No problem.
there's no parallel leak. There's no significant gradient, and the posts are parallel, so we don't need to post still for now.
Yeah.
And we'll call it a day.
Dr. Rashedan, he's having a question, I think.
Thank you, Dr. Walid. Great case, excellent outcome. But if you compare this platform to other self-expanding valve, would you have done anything different, or would go exactly the same approach?
I would still, because of the coronary access, if she's for example 80 years old, maybe you can entertain the other self-expanding platform. But for her age, I think this is the best way to have a proper coronary access. In addition, planning for another redo TAV in case required. I think that's the 2 points that really highlight the need, especially with an LED lesion that she might need it in the future. I think this is a proper platform suitable for this patient.
I'm quite happy that now with the advancement of these transcatheter therapy, now we have different platforms, and these platforms actually serve a specific group of patients, because coronary access was a big concern in the TAVI group. But now with the different companies and different platforms, I think this will actually give us a clear indication of which patient fit better platform. Thank you, Dr. Walid.
Excellent. Waib?
Yes, I have a question. First of all, thanks for this very nice case, very illustrative. But what's your practice now if you have a coronary lesions that need to be done? Would you do it in the same setting, especially with this platform that makes the coronary access very easy?
Did you hear the question, Shabab? If you have previous coronary artery disease, do you still going to go with the same type of platform, or you will do differently?
No, I still go with the same platform. The patient doesn't have angina that warrants us to
No, but
fix.
if you have a lesion that need to be
Intervened, like a different patient. It's
will
a
you do
different
it in the
scenario.
same setting? You do it in pre or post? What's your practice here?
I would do pre, if this indicated.
Yeah, if it's
So-
significant, proximal, I don't think you need a hustle later with any
It depends-
platform. But
Yeah.
you know, the trials are contradictory, to be honest with you, and a lot of practice changes.
Yeah.
We're using or doing the pre PCI and intervention routinely before every TAVI. Nowadays, it's not the case.
Yes, this is
Yeah, I know your
the practice nowadays.
Ahmed.
And so, regarding, to be honest, the conduction, I was commenting here. I know everybody is complaining about the radial force of accurate neo, but it's the same radial force that we like because we don't cause a lot of conduction problems. Most of the cases we rarely need any pacemaker, and you can see here with the Tal and the rest of the team that here the conduction looks great, even though the patient does have a conduction problem with a pre-existing AFib.
I think we are, at least in our center, we are using this platform for a while, and we are in one of the small registry. So far, we are happy with it. We never had a major complication or even minor. Because if you take your time, especially when the case is a trial case, you have to give it more attention because this will affect the data. And this is what they did today, almost as if they are doing a trial. And I like the practice. Go ahead.
Because if you use other self-expandable valve, it's actually sometimes it's fully retrievable even before you finally deploy. But I think with this platform, the retrievability is a little bit an issue, right? If you go from step 1 to step 2. I just want to hear from you because I don't use this platform.
Retrieval of the device.
If he wants to reposition.
Or Talal, do you want to take this? What's your recommend if you need the retrieval? Then we will come to Ahmed.
Yeah, so this platform actually, if once you open knob 1 completely, then it's not retrievable anymore. But the new Prime actually it's retrievable.
Yeah.
So the new generation it's coming, I think next year, it's retrievable.
That's why I questioned them during the live. Did you complete 1?
Yeah.
Because you should not complete step 1. You should not unless you are happy. Because you can go back and readjust your valve. And actually, it's one of the most stable valve you will touch in your life.
And the commissural alignment it's much easier than using the other platform,
Yeah,
right? Because
of that anatomy.
Yeah. Well, with the new system, actually, this is the accurate new, but with the new system, accurate prime is the commissural alignment is more easier and more clear, and even the release as well with the new system. Yeah.
The guys did it very quick because they are very slick. But it's and it's not that difficult, but they did it great. You can see it in the shots that's for the BVL. You can see the lift main marked over very nicely.
On behalf of my colleague here and the audience and GIS, I would like to thank Dr. Talal, Dr. Walid, and University Hospital and the company, Ahmed Takroni. He's always with us everywhere, running between Jeddah, Mecca, and Riyadh. Thank you very much. Very nice and successful case. Thank you.
Have a good
Very nice case.